Hello, thank you for tuning into our presentation. We will be sharing with you an understanding of severe asthma. I am Dr. Rohit Katial, Professor of Medicine at National Jewish Health, and I'm joined with my colleague, Dr. Nicole Chase. This program is promotional, presented on Amgen and AstraZeneca's behalf, and has been reviewed consistent with Amgen and AstraZeneca's internal review policies. This program is not CME accredited, and no CME credits are associated with this activity. So let's begin with a typical patient that we see in our asthma clinic, Alyssa. Alyssa presents today for follow-up after having had an urgent care visit. She was seen in urgent care 2 weeks ago with an acute exacerbation requiring a course of oral corticosteroids. She's improved, but now reports chest tightness upon awakening in the morning, wheezing, and cough requiring daily short-acting bronchodilator use or rescue medicine to relieve her symptoms. This is her second oral corticosteroid course this year. Her current medications include high-dose inhaled corticosteroids and long-acting bronchodilators, and as mentioned, short-acting bronchodilators for relief. Her past medical history is significant for the onset of asthma in early childhood, allergic rhinitis with runny nose, sneezing, and nasal congestion. She has experienced 1 to 2 exacerbations per year for the past 5 years. She is 38 years old, works full-time, lives in the suburbs, and commutes downtown for work. Her lung function shows that her FEV1 percent predicted is 65%, and her last visit was approximately 6 months ago. Her laboratory analysis shows us a blood eosinophil count of 380 cells per microliter, a total serum IgE level of 300 international units per milliliter. Fractional exhaled nitric oxide measurement was not available, and she demonstrated positive allergy tests to cockroach, dust mite, grass, and cat. So one question we could all ask is, could Alyssa's severe asthma be driven by multiple inflammatory pathways? So here on this graphic, you see the airway epithelium. The airway epithelium is the part of the airway that interacts with the external environment. And we all breathe in so many different types of particulate. But here you see the classic exposures, such as allergens, viruses, pollutants, bacteria, and other external triggers. Once the asthmatic airway is exposed to these particulates, it gets turned on and starts releasing pro-inflammation mediators referred to as epithelial alarmins. There are 3 primary epithelial alarmins. TSLP, thymic stromal lymphopoietin is what that stands for, interleukin 25, and interleukin 33. TSLP is an interleukin, but it has a funny name because it was originally described in thymic stromal cells. Once these epithelial cytokines are released, or they're frequently referred to as epithelial alarmins, particularly TSLP, then cells that are downstream or deeper in the airway get activated, and they further release more TSLP. These cells are dendritic cells, mast cells, macrophages, and basophils. And this, in essence, now has an amplifying effect to what was already released from the airway epithelium after exposure to external insult. It is also important to note a central characteristic in asthma is smooth muscle dysfunction or bronchial hyperreactivity. Research has shown that the airway smooth muscle also can release TSLP, and that TSLP that is released from the smooth muscle then interacts with cells that I just showed you, such as basophils and mast cells that are also in the airway. This bidirectional talk between the airway smooth muscle and the cells that are causing inflammation can then lead to that bronchial hyperreactivity that we're accustomed to measuring in severe asthma. So here on the graphic, you see the entire picture. We inhale all sorts of triggers, such as allergen. Those triggers then activate the airway epithelium. The epithelium releases the alarmins, such as TSLP, which then goes downstream into the airway and activates all the other cells that we just talked about. Those cells further amplify the inflammatory process by releasing more TSLP, and additionally, the airway smooth muscle is involved, which also releases TSLP and demonstrates some element of bronchial hyperreactivity. How do we know that the TSLP is coming from the airway epithelium? Here on this slide, you can see staining for TSLP. On the left is a normal non-asthmatic airway, and on the right is an asthmatic airway. We've used a stain that colors orange that is specific for TSLP. And on the left, in the airway epithelium, you don't see any orange yellowish staining, suggesting there's no TSLP expression. On the right, you see enhanced orange to yellowish staining, telling us that that is the source for TSLP expression. And that serpiginous looking area is the airway epithelium on the right. So in this cartoon, what we know is once the epithelium is activated and releases these alarmins such as TSLP, then other interleukins are also released from these cells that we've just talked about. The three key signature cytokines that we refer to as T2 or type 2 cytokines are interleukin 4, interleukin 5, and interleukin 13. Although these three cytokines have multiple functions, the primary function of interleukin 4 is to enhance production of immunoglobulin E, or referred to as IgE, which is the allergy antibody. Interleukin 5 is the primary growth factor or driver of eosinophils, so drives eosinophilic inflammation in the airway. And interleukin 13 drives mucus production in the airway, and we know that lots of mucus is a hallmark feature in severe asthma. Additionally, one of the biomarkers that we measure in severe asthma is referred to as exhaled nitric oxide, and that is also driven by interleukin 13. And finally, as I alluded to in the previous slide, there's mast cell involvement, which interacts bidirectionally with the airway smooth muscle, both releasing TSLP, leading to what we believe is the mechanism for the bronchial hyperreactivity seen in asthma. Another hallmark feature in severe asthma is mucus plugging. We talked about mucus secretion from the IL-13 pathway. We also talked about eosinophils. All the mucus and the dying eosinophils and the new eosinophils coming in interact to create these mucus plugs occluding the airway. This is a newer feature that we measure in severe asthma, and we'll share that with you throughout this talk. There's an NIH-supported severe asthma research program referred to as SARP, and in that study, 96 patients with severe asthma were analyzed, and approximately 68% of those patients demonstrated evidence of one or more mucus plugs in their airway. So if we move from the bench to the bedside, TSLP has been associated with various observations clinically. First, TSLP levels are associated with increased asthma severity. TSLP levels are also associated with increased asthma exacerbations, reduced lung function, and increased airway hyperresponsiveness. So let's get back to Alyssa and summarizing Alyssa's workup of her uncontrolled asthma. She's uncontrolled despite high-dose inhaled corticosteroids and long-acting bronchodilators. She's demonstrated an elevated total IgE level with positive allergy skin testing, and she's demonstrated elevated circulating blood eosinophil levels. So this suggests that there are multiple pathways that are in play that are potentially driving or underlying airway inflammation. Getting back to that ISAR, Severe Asthma Registry, they analyzed 1,175 subjects in this registry, and they reported that approximately 2/3 of the patients had 2 or more biomarkers elevated, such as we also see here with Alyssa's evaluation. So now I'm going to turn it over to my colleague, Dr. Nicole Chase, to share with you the clinical data for TEZSPIRE.
Thanks, Dr. Katial. So let's jump in and start talking specifically about TEZSPIRE or tezepelumab-ekko. As by now you are well aware, TEZSPIRE, which is referred to in the generic form as tezepelumab-ekko, it's a TSLP blocker indicated as an add-on maintenance treatment of adult and pediatric patients 12 years of age and older that have severe asthma. It's not indicated for the relief of acute bronchospasm nor of status asthmaticus, and if someone has a known hypersensitivity to tezepelumab or its excipients, TEZSPIRE is contraindicated. TEZSPIRE is the first and only treatment for severe asthma that blocks TSLP. As we've just gone through, TSLP is a key player for lots of downstream pathways, and so this is why it's so important to understand this medication. I'm going to show you some data on TEZSPIRE and remind you that in the clinical trials, it enrolled a broad all-comer population, regardless of asthma phenotype, regardless of biomarker profiles. And so we'll walk through this data and important safety information. But I also want to share with you some data that I find really, really insightful in terms of the proposed mechanism of action of blocking TSLP. So when I think about medications, I think about the way that I'm told that they should work and the actual clinical data. So as we learned in Dr. Katial's presentation, if we really are blocking TSLP at the top of this inflammatory cascade in patients that have asthma, what we should expect to see is that the biomarkers that come downstream from that cascade, those should all be decreased. So what I want to walk through with you here is the decrease in these biomarkers over time. Let's start on the left with peripheral eosinophils. Now, you've seen data that eosinophils are one of the key cells that are involved in severe asthma. What we know is that in the orange here, patients that received TEZSPIRE compared to patients shown in gray that received placebo, you see that those peripheral eosinophil counts drop precipitously even after the first administration of TEZSPIRE. You can see that those time points there on the x-axis are weeks, and so even by 2 weeks we see a decrease in eosinophil counts. If you follow that line out to the right, you can see that at 52 weeks of study, there was a decrease in peripheral eosinophils compared to patients who received placebo. As Dr. Katial mentioned, IL-13 is a key driver of exhaled nitric oxide. So when we check exhaled nitric oxide in our patients, we should expect to also see a decrease compared with patients who didn't receive TEZSPIRE. And again, in orange TEZSPIRE, you see here that even at the first time point of 2 weeks after administration, this decrease is compared to patients who received placebo. And as well, it's also nicely sustained out to 52 weeks of treatment. So you see that nice separation in patients who received TEZSPIRE compared to patients who received placebo. Finally, as we discussed earlier, IL-4 is a key driver for the production of IgE through class switching, as well as B-cell transformation to plasma cells. So seeing as we're not really suppressing the type 2 inflammatory response here, we're just turning it down. What we're seeing is that IgE production doesn't drop as precipitously as things like peripheral eosinophil counts or exhaled nitric oxide. But because of the way IgE is made, we would expect that. So we would expect to see a gradual reduction in class switching and IgE production as those currently existing B cells and plasma cells live out their natural lifespan. And as you see here in the graph, patients in orange had a very nice gentle decrease of their IgE levels, and patients who received placebo actually had an increase in IgE levels, so that at 52 weeks you again see separation of IgE. The mechanism of action here has not been definitively established and the results are descriptive only. I do think, though, that it's nice to see that what we think is happening actually plays out in terms of the biomarkers that we're able to monitor and manage in our patients. So for a long time, we've really been kind of subjected to what I would like to call the bait and switch aspect of severe asthma. In that we think that patients that have severe asthma, that if we draw peripheral blood eosinophils, that's good enough to tell us what's going on, not only in the blood, but also in the lung tissue. And so this study, I think, really does a great job of, those of us who have kind of said, I believe that to be true, but I would love to see some data. Here's the data. So in this study, patients were enrolled and actually underwent bronchoscopy while being treated either with placebo or with TEZSPIRE. You can see on the left that this is a graph indicating the presence of airway submucosal eosinophils. So not just peripheral blood eosinophils, but eosinophils in the lung tissue. As shown here, patients that received placebo compared to patients who received TEZSPIRE, there was a reduction in the presence of airway submucosal eosinophils in patients who received TEZSPIRE compared to those who received placebo. A picture is always easier to explain these concepts, and so on the right, what you see is airway submucosal staining of a specific protein called major basic protein, which is a key eosinophil protein. And what we see is that in the histology of patients at baseline, you see lots and lots of that major basic protein as circled in orange. And then EOT stands for end of treatment. You see here that there's been a decrease in the presence of major basic protein, which correlates with that decrease in the presence of tissue eosinophils. So not only are we seeing blood eosinophil decreases, we're also seeing that TEZSPIRE can impact the presence of tissue eosinophils. The way I like to think about asthma is that it really is a very heterogeneous disease where you have multiple different phenotypes, multiple different endotypes. We use what we can to try and really stratify patients, but at the same time, people really are different in terms of even their severe asthma. One thing that we've always known that we could do, however, is exclude patients that don't have asthma, or really look to see who doesn't have one of the hallmarks of asthma. Seen here in this graph, patients that received TEZSPIRE had a reduction in airway hyperresponsiveness as measured by a mannitol challenge. So as you remember, in a mannitol challenge, what we do is we take patients and then we give them very small but increasing doses of mannitol and look and see when their airways start to become hyperresponsive or twitchy. And the way that we measure that is by checking FEV1 after each dose. So you see here that in gray, patients who received placebo, they really only required about 58.6 milligrams of mannitol to induce a 15% decrease in their FEV1. In contrast, patients who were given TEZSPIRE, it took 197.4 milligrams of mannitol to equal the same 15% decrease in FEV1. That's almost a 4-fold increase in the amount of mannitol. I've shown you evidence for inflammation, and now this is the evidence for airway hyperresponsiveness. The mechanism of action here has not been definitively established, and the results are descriptive only. Dr. Katial did a great job describing this concept of mucus plugging and how we're really starting to think about this more and more, especially in patients that we see in clinic. So we know that many patients will complain of mucus production, but really here we're focusing on this idea that IL-5 and IL-13 together impact this role of eosinophils and production of mucus together to cause mucus plugging. And what we know is that this is significant clinically for symptoms, but also mucus plugging is commonly found in the airways of patients that have severe asthma. As you can see in the graphic, on the left, patients that have mucus plugging at baseline, then at the end of treatment with TEZSPIRE, you see a decrease in the actual presence of these mucus plugs. And there was actually a 62% reduction in the number of patients that had mucus plugs from baseline compared to the end of treatment. So really, if we think about mucus plugging as being another factor in terms of how we think about asthma, it's nice to see that TEZSPIRE can have an impact directly on that. So let's get into the trials that were submitted to the FDA to receive approval for the use of TEZSPIRE in patients that have that severe asthma. More than 1,300 patients were studied. The two key trials were the Pathway study, which was published in 2017, and the Navigator trial, which was published in 2021. As you can see, there was a significantly increased number of patients in the Navigator study compared to the Pathway study. But both studies started with a run-in period followed by an active treatment period of 52 weeks, where patients would receive either TEZSPIRE 210 milligrams subcutaneously every 4 weeks, or they would receive placebo every 2 weeks. That was in the Pathway study. In contrast, in the Navigator study, the difference here, in addition to the increased numbers of patients, was that patients who received placebo actually received a subcutaneous injection every 4 weeks as well. There was a follow-up period of 12 weeks after the active treatment period, and patients who enrolled in these studies had to have an exacerbation rate at least of 2 in the past 12 months. They had to have an ACQ-6 of greater than or equal to 1.5, and then they needed to be taking either medium or high dose ICS with additional controllers. Patients were excluded if they had clinically important pulmonary disease other than asthma. The primary endpoint in both trials was met, and TEZSPIRE demonstrated statistically significant reductions in exacerbations, 71% decrease in the Pathway study and 56% decrease in the Navigator study. So let's think about the different phenotypes and endotypes of patients that were enrolled in the Pathway and the Navigator trials. As I may have mentioned earlier, there were no biomarker restrictions for these patients to actually be included. They needed to have severe asthma, but otherwise they could have any biomarker levels. After that point, there was a stratification that was done to start with patients that had blood eosinophils that were greater than or equal to 300 cells per microliter, as well as any positive testing for a perennial aeroallergen sensitization. So really, what we're focusing on today are those patients that initially were enrolled in the trials, had elevated eosinophils, and then also had evidence of concomitant allergic inflammation. And I think the point of this is that these are the patients that we commonly see in our asthma clinics, patients that usually have a little bit of allergies as well as a little bit of peripheral eosinophils. So if we look at this group of patients that had allergic and eosinophilic asthma, arguably the most common patients that we see in asthma clinic, we saw that there was a 79% decrease in exacerbations in the pooled data from the Pathway and the Navigator studies. These results are not multiplicity protected. Results are descriptive only. In addition, there was a 93% decrease in hospitalizations, urgent care, or emergency department visits due to exacerbations compared to baseline. What we haven't talked about so far is lung function changes in these patients. I'm happy to show you this data of the role that TEZSPIRE can make in terms of treating patients with allergic and eosinophilic asthma. So if we look at the first time point after dose administration, so 4 weeks later, you can see that the pre-bronchodilator FEV1 had an increase, and that over time this increase was not only sustained, but continued to grow, and that at 52 weeks, the improvement was 370 milliliters compared to baseline. This is showing adverse reactions in patients who received TEZSPIRE or placebo that had an incidence of 3% or greater, and also that the TEZSPIRE adverse reactions were more common than placebo. These included symptoms of pharyngitis, arthralgia, and back pain. And you can see here, these occurred at an incidence of 4% compared to 3% for patients with placebo. The pooled safety population from both the Pathway and the Navigator studies included adults as well as adolescents. So let's switch to talking about how do we actually dose TEZSPIRE and how do our patients administer? So this is very straightforward. All patients that qualify for treatment with TEZSPIRE should receive the same fixed dose strength every 4 weeks. That's it. There's no loading dose. There's no dosing schedule where it might change over time. There's no dose adjustment required based on your patient's weight, especially if that fluctuates over time. And there's no dose adjustment based on a biomarker level. Remember, in the clinical trials, you could have any biomarker level at all and qualify for treatment with TEZSPIRE. There are, however, 2 administration options, and this is a great time for shared decision-making with your patient. If the patient is best served by receiving TEZSPIRE in office, then you should use a pre-filled syringe for administration. If the patient qualifies for at-home treatment, then the pre-filled pen is right for them. Let's review that important safety information that I mentioned earlier. As you know, if someone has a hypersensitivity to the active ingredient in TEZSPIRE or its excipients, TEZSPIRE is contraindicated. There have been hypersensitivity reactions that were observed in the clinical trials, such as rash and allergic conjunctivitis, and there have been reported cases of post-marketing anaphylaxis. In general, if a patient has a hypersensitivity reaction, you should pursue a risk-benefit analysis and talk with the patient to decide whether to continue or discontinue treatment with TEZSPIRE. TEZSPIRE is not a treatment for acute asthma symptoms, exacerbations, bronchospasm, or status asthmaticus. And please remind your patients that even if they do start to feel better after administering TEZSPIRE, they shouldn't stop taking their systemic nor inhaled corticosteroids abruptly or decrease them without the supervision of their provider. We know that this can cause adverse outcomes and/or unmasking of other conditions. There's a concern about parasitic infections, given that we're talking about the effect of TEZSPIRE on eosinophils. It's not known if this will influence a patient's response against parasitic infections, but if your patient has a parasitic infection, you are recommended to treat them before initiating therapy with TEZSPIRE. If they do contract a parasitic infection while receiving TEZSPIRE, you'd want to treat them, and if they don't respond to treatment for the parasitic infection, then you can hold TEZSPIRE until that infection resolves. There's no data on live attenuated vaccine use concomitantly with TEZSPIRE, and so the use of live attenuated vaccines should be avoided. We went through the most common adverse reactions compared to placebo: pharyngitis, arthralgia, and back pain. And finally, There's no available data on the use of TEZSPIRE in pregnant women. We do know that placental transfer of monoclonal antibodies is greatest during the 3rd trimester of pregnancy, and so this should be a decision that's made upon jointly between the patient and the provider. So let's review. We talked about the role of the airway epithelium and the smooth muscle as producing one of these alarmins, TSLP. We know that TSLP can drive downstream pathways associated with the canonical cytokines of type 2 inflammation, which are IL-4, IL-5, and IL-13. And then we talked about the role that each of these interleukins plays in terms of the pathology of those hallmarks of asthma: inflammation, airway hyperresponsiveness, and mucus production. IL-4 is involved with IgE, IL-5 is what we think about in terms of eosinophils, and IL-13 we think about exhaled nitric oxide and mucus. And then don't forget that I shared with you that data about airway hyperresponsiveness and the mannitol challenge. TEZSPIRE really is the first and only respiratory biologic that blocks TSLP. Please remember that patients that were enrolled in the clinical trials for TEZSPIRE were broad, all-comers, regardless of phenotype or endotype, and that the use of TEZSPIRE compared with placebo reduced exacerbations by up to 71%. If we think about patients like Alyssa, where she has allergic and eosinophilic asthma, we saw a decrease in exacerbations of asthma compared with baseline, 79%, and a decrease in those asthma exacerbations that would require hospitalization or other forms of immediate care. So I really want you to think about choosing TEZSPIRE when you think about patients that have severe asthma, those that are patients that have evidence of allergic inflammation, as well as eosinophilic inflammation. Thanks so much to all of you for your participation today and your presence here. Dr. Katial, I thank you for joining me for this presentation. This does conclude today's program. Scan the QR code on your screen to get the full prescribing information for TEZSPIRE, including patient information, at tezspirehcp.com. Thank you again, and good day.